Hello, ladies and gentlemen. I'm Koen Deloose, head of the Department of Vascular Surgery in AZ Symblasius Hospital in Dendermonde, Belgium. And I would like to tell you something about my view on the near future of vascular disease treatment. So these are my disclosures, as you can see. And so to answer the question, well, for me, the near future is also the current status. The future of vascular disease treatment, in my opinion, is the use of paclitaxel-coated balloons. Why? It is quite clear the efficacy is extremely high. We knew already based on the proof of concepts at 6 months, where you see tremendous late lumen loss differences compared to the plain old balloon angioplasty. We know that it works at 1 year, as you can see in several studies, primary patencies, TLR rates, much better than the plain old balloon angioplasty. If we are even looking on the longer run, so medium term, up to 2-3 years, you see here in these data sets again a huge advantage of paclitaxel coated balloons versus non-drug-eluting technologies. And if we are looking at the longer run, up to 5 years, you see that in the FPAC trial, the Ranger trial, the ACO-R trial, the IMPACT trial, so a lot of studies, randomized studies are available showing the higher efficacy of these paclitaxel-coated balloons versus non-drug-eluting technologies. There was a remark concerning, or a concern concerning the safety. Well, we see that this was just a meta-analysis based on the literature ending to this conclusion. But if we are looking at an updated patient-level meta-analysis, where we are looking also not only at the intention to treat, but also at the as treated population, the late crossovers, and the crossovers at any time, then you see that there is no signal of unsafety and mortality anymore. And even when we are looking at other randomized controlled trials like the SweetPath, like the Voyager PAD trial, you see no signal at all. And also tons of observational data cannot confirm an unsafety for paclitaxel eluting devices. Even more, and I want to state the opposite together with a lot of other key opinion leaders, published this year in the JAG, showing that the risk of amputation or death was higher in the post-paclitaxel period compared to the pre-paclitaxel period. So very clear that the restriction to paclitaxel devices really caused some harm to our vascular patients. And this was also confirmed by Marianne Brodman this year during the LINC meeting, where she presented a true PTX comparative analysis in a lot of patients. More than 10,470 patients were analyzed, and it was quite clear that treatment with non-drug-eluting devices was really increasing the amputation rate and also the readmission rate in the hospital. So for the people who are still not convinced that paclitaxel coated balloons are safe, is a limus eluting balloon an alternative? Well, we know that there are two big groups, two big devices, the Magic Touch device and the Solution limus eluting balloon, studied in several registries, as you see here. And with the Sirona trial, with the Magic Touch, we have also a randomized controlled trial available, where 238 patients were randomized in a limus eluting balloon versus 244 in the paclitaxel eluting group. And so it was a non-inferiority trial comparing the sirolimus coated balloon versus the paclitaxel coated balloon. And you see here the results in 482 patients, 73.9 primary patency at 1 year for the limus versus 75% for the paclitaxel. So non-inferiority was proven. If we are looking at primary safety endpoints in terms of clinical driven TVR, major amputation and death. Also there you see that there are no statistical significant differences between both groups, but there is still a trend that the paclitaxel eluting balloon is doing better. If we are looking at the other Limus eluting balloon, the solution, here you see all the trials that are running right at the moment. Especially I'm interested in the randomized controlled trials at the right, but you see that they are still in US enrolling these kind of patients. I just want to show you some insights in the success study, a real world all-comers registry, where they notice freedom from clinical driven TLR of 91.1% in a full cohort of patients, 720 patients. If we are looking at some other parameters in terms of clinical outcomes, you see also here quite good results. But if we are putting this in perspective with paclitaxel eluting devices for same lesion length, same amount of calcium, CLTI versus claudicants, you see that there is no substantial difference between Limus and paclitaxel coated balloons. So is Limus an alternative? In my opinion, not, because you see just non-inferior results, but at a much higher price. You know that the engineers, they really need to make nano carriers, more complex technology to bring the non-lipophilic Limus into the vessel wall, to keep it there, not to create a wash off. And so this means much more expensive technology with the maximum non-inferior results. So I would say, are there no issues with paclitaxel coated balloons? Yes, there are some clouds in the sky. We know that there are some data about positive remodeling or pseudoaneurysm formation. There is a lack of evidence below the knee, and there is also the reporting of slow flow phenomenon. In terms of a pseudoaneurysm formation, it is definitely a case, but if we are looking a little bit more in detail in the literature, we notice that it is mainly with the polymer-based drug-eluting stent, the Eluvia, that it is reported, like here in the capsicum registry, up to 17% aneurysmal degeneration. If it happens with paclitaxel-coated balloons, in the vast majority of the cases, it is in combination with atherectomy, so probably creating the trauma of the vessel wall by two deep cuts by the atherectomy devices, and then of course adding some paclitaxel can create this pseudoaneurysm formation. The predictor here are the extreme complex, difficult revascularizations. There is also, and we cannot deny this, a lack of evidence in below the knee with paclitaxel-coated balloons. Here you see a meta-analysis that was published in 2020 in the European Journal of Vascular and Endovascular Surgery, where it is quite clear that no significant differences in limb salvage, survival, restenosis, TLR, and amputation-free survival rates were found between DCB angioplasty and standard plain old balloon angioplasty. So I don't know why this is, why we have this lack of evidence below the knee as we have so much evidence above the knee. Do we need to do better patient or lesion selection? Did we not find right now the correct endpoints for a CLTI BTK trial? Are there some procedural shortcomings? Do we need to do better prepping, more prolonged inflation? Is there a problem with intravascular imaging or with sizing? Are we using the wrong strategies? All open questions. Are we using the same wound care protocols, and so on and so on? And last but not least, probably, are we potentially using the wrong paclitaxel-coated balloons? And this brings me to the third issue with paclitaxel-coated balloons. It's the particulate embolization and the so-called slow flow phenomenon. It's seen in coronary world, but also in the peripheral world. So there are definitely publications on this, and there are also some preclinical histological analysis where it is quite clear that when you treat with some first generation paclitaxel-coated balloons your patients, and especially the CLTI patients, that there is the risk of particulate embolization to the distal bed. The slow flow phenomenon has a direct impact on the outcome. If you are looking here, freedom from TLR restenosis, amputation-free survival, much lower in the slow flow group compared to the no slow flow group in this analysis. Having said that, I'm still a little bit in doubt concerning the clinical outcomes, as it is proven in different papers that there is no increase in amputation risk with paclitaxel coated balloons, and also no increase in mortality, amputation or cardiovascular events in the CLTI population with paclitaxel coated balloons. I think personally that, and this is also quite clear out of this table, where you see quite high percentage of embolization events, but it is a tremendous heterogeneous reporting. Angiography in the microdistal embolization is not sensitive enough, but there are event rates up to 39%. I think personally this is not only caused by paclitaxel or by drugs. There is also micro debris of the pathology, but it happens much more common than we think. There are a lot of unexplained events that probably can be explained by this distal embolization. And I think the more aggressive our endo approach in the more extended distal disease, the more vascular aging you get and the more problems you get with this distal embolization. Of course, I'm not sure that we can consider all the drug-coated balloons or the paclitaxel-coated balloons as the same. There is no class effect. There are huge differences in technologies, and especially on the excipient and the coating technology, there are some important differences. And I want to stress a little bit on the leg flow, rapid exchange or over the wire, and the longer leg flow XP also in bigger diameters available. Here we are talking about an excipient of ammonium shallowick salt and a coating technology, the SafePax amorphous matrix coating technology. And I go a little bit more in detail. Why is this ammonium shallowick salt so important? It is really creating a lipophilic surface that is rejecting the water, repelling the water, so there is no risk of wash off during the way to the lesion, and it creates also a very smooth and elastic surface due to the SafePax amorphous matrix coating technology. And so this is really creating a paclitaxel layer, homogeneous amorphous paclitaxel that is not washing off and that is penetrating very well into the vessel wall. So here you see more in detail, 2,000, 5,000 times magnified, the difference between the leg flow cardionovum coating and a competitor. You see clearly this crystalline structure that is prone to distal embolization, and one movie is saying more than 1,000 words. Here you see the inflation on the left side of a competitor, on the right side of the leg flow, and you see the flaking of debris of paclitaxel from the competitor, and nothing happens on the right side with the leg flow of cardionovum. This is not only a marketing talk, this is also proven in a clinical program, and I want to present you the leg depth study that was published in 2019 by Eugenio Stabile. The leg depth study, 139 patients in 4 centers in Europe. Fempop lesions were treated with a mean lesion length of 9 centimeter, occlusions in 1 out of 3 of the patients. And here you see the fantastic primary patency at 1 year, 81.1%, and a freedom from TLR at 1 year of 83.2%. Relatively easy lesions, so also proven in more complex lesions. The reflow study done by our group, you see also here we are enrolling task C and D lesions in 120 patients with a mean lesion length of 22 centimeter, occlusions in half of the patients, very calcified in 2/3 of the patients. And even with this extremely complex population and lesion cohort, you see that we are reaching primary patencies up to 2 years of 70.5% and freedom from reintervention at 2 years in 76.1% of the cases. Of course, we are also waiting on the results of an RCT trial, DCB versus plain old balloon angioplasty in the FEMPOP area in 148 patients, the signature study. And so I'm really looking forward to discover together with you the clinical driven TLR results at 1 year. So in conclusion, I can state that paclitaxel coated balloons are performing excellent in terms of efficacy and systemic safety. Because of this reason, I think this is the current state and the immediate future for endovascular treatment in PAD, especially the slow flow phenomenon, the distal embolization, and consequentially also the potential CLTI BTK failures remain issues to solve. Not all paclitaxel coated balloons are the same. There is no class effect. I think that the leg flow paclitaxel coated balloon of Cardionovum with its lipophilic ammonium salt excipient and very homogeneous amorphous SafePax coating technology creates this stable and smooth surface without the risk of distal embolization and slow flow phenomenon. The clinical program with the leg depth study, with the reflow study, proves already its safety and efficacy in simple and in complex lesions. And we are waiting for randomized data in the signature study to confirm this efficacy and safety. I thank you for your attention.